good evening, everyone. And I just want to sort of share with you the start to this evening's talk, because I think both Andrew and I have been stuck in various motorways across the UK. So it's really nice to be sat here and welcome you to this evening's Maternity Marmite series. And just to start off with, some of you may have dialed into the previous CPD Me event where we covered breech birth. And what I normally like to do is to talk about these education sessions in the context of what it's like to be out there and walking in the shoes of our pre-hospital clinician colleagues, and also to really think about what's going on for us when we attend these jobs, when we don't generally or necessarily have lots of information about what to expect. And often that's simply because when someone rings for an ambulance or they ring a 999, and particularly in maternity where something can happen quite unexpected or it's an emergency, sometimes it's really difficult to articulate what the problem is. And certainly in my experience with the ambulance service, of listening to calls when an emergency is happening, whether that's a woman ringing in or whether that's a partner or a bystander, sometimes it's very difficult to get at what the problem is, and sometimes some of the information you get is actually difficult to really discern what's going on. So tonight we're going to be thinking about what happens with a cord prolapse, the obstetric emergency. And before we start, I'd like to get everyone to pause for the moment. And I'd like us to think about, when we think about maternity jobs, maternity calls, when we think about the thought of the umbilical cord hanging out or being prolapsed, or if you've never seen an umbilical cord before or what it feels like, have a think about what might be going on in your mind, what might be happening, and how might that affect your face, how that might affect how you approach that job. So without further ado, and enabling us to have a think about this in a bit more detail, I'd like to present us first of all with a maternity call. And let's see what's going to be happening tonight, because I've certainly just been informed that there's a few maternity calls waiting, and I can see, looking at my screen, we've got 34 people attending. So in my book, that's lots of expertise around the country that are listening into this. So I'm hoping that you're going to help me manage this maternity call, because although I'm a midwife and I work in the pre-hospital setting, wow, I still get scared about things. So let's have a look. Shall we see who's rung in this evening and what they're telling us? Okay, so, there's one of our emergency medical dispatchers, Davika. She's answering a call. And it's coming in from a man who says, my girlfriend's just come out of the mosh pit and there's green stuff running down her legs. Yeah, she's breathing okay. Yeah, she's breathing. Yeah, but you know, get an ambulance quickly, you know, because there's green stuff coming out. Oh, there's something slimy too. Oh, I'm not sure what that is. So I want us to pause there, because often for our medical dispatchers, sometimes the history that we get doesn't always tell us about what's really going on. And across the country, most of us use the medical priority dispatch system to triage calls, and some of our ambulance services use pathways. So depending on what information we have available during that call will mean that that person looking at the call and the history will then provide the emergency dispatch response. So at this point, we start to think, well, what's really going on? And let's have a think about this. So there's something going on where she's at a mosh pit. So she obviously likes perhaps loud music, and there's a lot of jumping about, and there's green stuff running down her legs. So I hope that you're still there. Yes, you definitely are. There's now more of you. So you're thinking, what's this green stuff running down the legs? What alarm bell is that ringing? And what does that mean? What's going on now? What am I thinking of? Are there any clues? Is it telling me that maybe her water's broken? And if they are broken, what does it mean? And what about this slimy? What does this mean to us? Well, we're doing a talk about called Prolapse, so you might suggest that, but who knows? Okay, so the call takers pop the call down the mobile data terminal to you, and tonight, everyone, you're going to be the solo responder, and you're driving around East Midlands on this sunny evening when this call comes in. Now, what I want you to think about is you've just qualified as a paramedic. You haven't seen any maternity calls as such or been to any emergencies. And you're really in a great mood because the sun's shining, and you look at the location and immediately you think, my goodness, so we've got a 25-year-old female, there's green fluid, and there's something in the vagina. Okay, that's not telling us much right now because there's a few things there. But what I'm thinking of is if we're on our own and the service is really stretched and we've got this information, and lo and behold in East Midlands, actually at that time, there's a festival going on and it's download this evening. So you're kind of thinking, well, do you know what? I don't mind a bit of rock music. Okay, this could be a really interesting call. So I'm going to go in, I'm going to put my chest out, I'm going to be really positive, and I'm going to make sure that we do the best we can because I'm not sure what's going on as yet. But you know what? This is going to be really, really interesting. So let's see what's going on there. And what am I thinking of? Well, no, she's a 25-year-old female. Well, we don't know she's pregnant, but there's something coming out of her vagina. So I'm going to hazard a guess that there might be a pregnancy here. So I don't know about you, but I've never been to download. But I've been to a few festivals, and already I'm always thinking when I get called out to go to a BBA as a midwife, I always have an image of my mind that's generally very positive, particularly as the eternal optimist, as the midwife I am. So this is what's going on in your mind. And I've put, what imagine this, but actually, what are you imagining? What are you thinking about? Because certainly, are you thinking about, I'm on my own, where is this woman? Have we got other crews there that can aid in finding her? What's going on? So there's a lot going on even before I arrived on scene. And when we talk about maternity emergencies and when we debrief our staff in the London Ambulance Service where I work, often even by the time they're arrived on scene, they're already thinking about, what do I need? What do I need to take out of the vehicle with me? What's going on? Actually, what was the last job I did? Am I still affected by it? And these factors are really important because every time we get a maternity call, it can be different. And as a paramedic, you may go to lots of different calls, and the maternity one may be the one that is the rare one that you go to. So actually, you get on scene, and certainly Kiss aren't playing at the time. But what is happening is it's actually looking like this. It's a really muddy evening out there at download, and suddenly all that positive vibe and that positive feeling is somewhat different as you go to approach this woman. And it's quite easy, it's pointed out to you, you've polished your boots, but hey, they're going to get a bit muddy. And you manage to find the lady, and you get there, and there's a few people around her. She's walking around, and it looks like her leggings or her jeggings are pretty much soaked. So what are we thinking about doing? What are our priorities? What do you need to do here? Okay, let's think about this. So certainly you're going to think about whether you need another resource on scene. Now, at a major festival, you may find that there is lots of resource available to help you here. The second thing you're going to be thinking about is that maternity pack. Do I need it? And certainly, do I need a paediatric or a neonatal resuscitation kit? And depending on which ambulance service you work for, you may find that this is packaged in your paramedic bag or an extra kit. But what is for sure is that you're still going to need to do that systematic assessment because you need to know what's going on. And certainly, often if we get the history that suggests actually there's something in the vagina or my waters have broken and they're green, then one of the things you're going to think about early on is part of your systematic assessment is, do I need to expose the vagina in terms of undertaking a visual examination? And if we think systematically through an A to G approach, which you can see on the screen now, let's just work through it, because a lot of the visual cues and the conversation we get to the woman is really important. But critically in this situation, what we want to do is think about, actually, is this an emergency? Have I got time to do a systematic assessment detailed enough that I can manage it on scene while I'm with the woman? And in the first instance, if this woman is looking well, she doesn't appear unwell, and actually she's talking to you and having a conversation, then at that point the priority is actually to have an expose of the vagina and see whether actually what you can see is anything visible. Now in this case with our lady, our 25-year-old female, as it turns out, she's got about 30 centimetres of very obvious umbilical cord hanging out of her vagina. It's the first time you've seen this. You're not quite sure what to do with it. It looks like it's pulsating. There's green stuff running down her legs. It's actually really dark green stuff. Both the lady and her boyfriend are looking at the green stuff and going, what is this? And actually, immediately, the level of anxiety in the situation can start to increase. Because what does it mean to that woman? What does it mean to you? What does the fact the umbilical cord is hanging out the vagina actually mean? And we're going to come back to that in how we can approach this systematically. But at that time, the most important thing you can do is recognise that this is an obstetric emergency. And until you have a conveying resource on scene, then actually there are certain position that you need to put this woman into, with the objective of relieving the pressure of that on that umbilical cord. And as you can see from this assessment that I've included on the slide, which has come out of one of our maternity assessment cards that we use at the London Ambulance Service, what you can see and what is normal in a pregnant woman is the waters have broken. She's more than 37 weeks of pregnancy, so she's at term and she could be going into labour. But we would expect the fluid around the baby to be clear. So in a woman whose waters have broken, either at less than 37 weeks or after 37 weeks, if they're not clear, if there's meconium present, explaining the green that is being noted by the mother and reported by the father on the initial call, that is not normal. And certainly babies, as they become mature in the womb, are more likely to have their bowels open incidentally. But it's when the baby is stressed and it passes meconium that's very, very thick and dark, and we may call it particulate, it may have bits in it, and this is of significance to the baby and it's significant to us. I'm going to go back to that a bit later on. So in this situation, you can see that part of the assessment we do, and we have it at the bottom, is we think about go, go, go. And that's because in an obstetric emergency, the only way we can manage this is being an obstetric unit near an obstetric theatre in case we need to deliver this baby in an emergency situation. So let's move on here and let's think about what's going on and what we need to do. What can we do if we're on our own and we've approached a woman and there's 15 centimetres of cord hanging out her vagina? That is quite a frightening thought, and it's a frightening vision in my mind as a midwife, let alone if I'm a midwife in the community, particularly if I've turned up to see a woman in her home to do an antenatal check and there's the cord come out. Even if I've gone to a home birth and the woman's in labour and the cord has come out, it's an obstetric emergency. And we're going to talk about what I could do as a midwife, but also what we can do as pre-hospital clinicians within the sphere of practice of a paramedic, but also how as a midwife I may be able to add an additional value if I'm present on scene. So in my previous talk on breech birth, I talk about 3Cs in a lot of stuff, and I think it's a really nice way to encapsulate different ways of approaching the management of an emergency. And in this case, we're going to use the 3Cs to think about how we're going to manage a cord prolapse and how can we make it safe for the baby. So let's think about this. Let's think about compression. And what does compression mean in this first instance? And this is our number one, okay, if we're working clockwise round. So compression on the umbilical cord is an emergency. And that is because when we think about the baby is receiving oxygen through the placental bed via the mother, so that is essential for the baby to function. But the umbilical cord also needs to remove carbon dioxide and waste products. So any compression that occurs on the umbilical cord means that the baby does not get oxygen, but at the same time it is not able to eliminate the carbon dioxide. And it is the retention of carbon dioxide that is very damaging to a baby in the long term. And certainly if we don't relieve the compression, there will become a point where the baby will become significantly compromised and potentially die. So our objective in this emergency situation is to do manoeuvres that relieve compression on the umbilical cord. Now you may not know what is compressing it. It may be the baby's bottom, but it may be the baby's head. So what we're trying to do is enable the mother to adopt a position where she can force the presenting part to come out of the pelvis. And here on the right hand side is a lovely picture of Emma. She's one of our clinical tutors, and this is her very kindly demonstrating a knee chest position. And as you can see, the pelvis is very much up in the air, and by doing this it enables the presenting part to drop down with the objective of relieving the compression of the umbilical cord. Now, if the umbilical cord is hanging out and it's very obvious, there's been a lot of debate about whether you use a wet cloth, whether you use a dry cloth, and actually, can you put a small proportion back in the vagina, or do you not touch it at all? And it's really interesting because when you look at the literature, a lot of what's recommended is based on theoretical construct rather than anything that shows improvements to outcomes with particular interventions. It's often just case studies. But what we do know is in the past we used to talk about wet towels because we thought that keeping the cord moist was really important. But we recognise that warm, moist towels also get cold. So in reality, some people talk about if you've got a small amount hanging out to place it back in the vagina where the vagina is warm and it's moist, and then you can safeguard it. But also at the same time, you've got to think about the privacy and the dignity of this woman. So actually enabling her bottom to be covered, safeguarding her, but also at some point you're going to consider where the ambulance is and actually getting her to walk to the vehicle at the earliest opportunity, because what you don't want her to do is be sat on her bottom or sat in a carriage chair. So that's the objective of relieving the compression on the umbilical cord. So working the opposite way round before we call ahead is communication. And communication is key with the mother because she's going to be very, very frightened, and particularly if she's in a position where she's looking down and her bottom's in the air, it's actually a very frightening situation to be, particularly if she's not sure what's going on and she's very, very frightened that there's a problem with the baby. So communication with the mother and really giving her the communication to demonstrate that you are recognising the emergency, but you're also taking steps to remove her as quickly as possible to the nearest obstetric-led consultant unit. So that communication with the mother is key. And it's also important because what she needs to realise is that actually that journey is going to be quick. There's going to be some flashing lights. It could be noisy. She's in the back of an ambulance, which she may never have been in. And actually this is particularly frightening. And in different cities where women may be booked at one hospital and be going to another, this can be very, very unpredictable. So it's really important that she can build up a relationship with you and feel safe with you. And that's all about how we introduce ourselves, but also about that whole bandwidth, about how we are interacting with the woman and making her feel safe. Because remember, women and their partners may believe that even though we may be wearing green, that we can listen to the baby's heart, that we can do various techniques and interventions that actually as a paramedic we may not be able to do. And even as a midwife, if we were on scene, we may be able to undertake something called filling the bladder, which could raise the presenting part and could potentially relieve pressure. And we'll come back to that, hopefully, when we have some questions to discuss. So the last chunk of this and the last third to think about is calling ahead. And this is really key because you can never underestimate the notice that you need to give to a maternity unit that you are planning on arriving. Now, this is key because we often consider that if we put a pre-alert in, that everyone on a labour ward is going to be ready. And if a labour ward is very, very busy and there's lots of caesareans going on and you have a whole team occupied in different rooms, then having an emergency means that you have to suddenly deploy everyone away from other emergencies. So the period of notice that you provide to an obstetric unit is really key, and you can make a real difference. Get it in early, communicate, We've got the woman on a knee chest position. We've got a cord prolapse with so many weeks of gestation. We will be with you in 10 to 15 minutes, or however you anticipate. So this is the 3 C's of how we're going to consider making this safe in the first instance. And certainly, once your crew arrived and you have your ambulance ready and you know it's nearby, then that's the right time to walk the lady rapidly to the ambulance. It's certainly not the right time to put her in a carry chair at all. And at the Download Festival, through the mud, it's not really happening, is it? Hopefully the wellies don't get stuck in the mud. So what about when we get onto the ambulance then? Let's have a think about this, because what you can see with Emma here in the picture is that she's lying on the left lateral. Her hip has been exaggerated upwards by what the crew have found is a vacuum splint. And we're aiming to elevate the lowest part of her hip above the lowest or the posterior shoulder. And the objective here is to enable that presenting part to fall down out of the pelvis and actually relieve any cord while you're conveying to hospital. Now, an important note here, and this has come up with various teams, and something that we will now be included in our updating the ambulance service, is about offering the mother the ability to actually be on the opposite side, so she can be on a right side with the exaggerated tilt on it. Because there can be nothing more frightening than facing the wall or the window of the ambulance, as you can see Emma is in here. Whereas, as long as her airway is clear and she's talking, then having her on the opposite side with the exaggerated tilt on her hip will mean that she can talk to you, you can carry on talking together and providing that ongoing reassurance, but at the same time you've got her safely secured in. We don't recommend conveying women on an all-fours position. Even if you have a midwife transferring with you, she needs to be belted down, and this is the safest option. It's also a very safe option, although not comfortable at all, is if a midwife has been on scene when you've turned up, that she may well have filled the bladder with a couple of 100 mils of water, and the bladder filling lifts up the presenting part, and then she can clamp the catheter, and that will remain in until the mother gets into hospital. Now, if that is in situ and the midwife has done that, then actually you should feel more reassured with the woman in this position, but women should not be conveyed in the knee chest position during the emergency transfer to the hospital. Okay, so we're conveying, we're going off to the nearest, and we've managed to leave Download, but the mother's feeling secure. You've built up a really good relationship. She's feeling safe. The dad's in the back. And actually, it's been really helpful because you've been able to find her maternity records. And what you've noticed is that there's only one baby inside, so that's a bit of a relief. That she's now 38 weeks of pregnancy. And actually, one of the things that we're going to start thinking about is, well, what happens with, what are these red flags I've got to think about if, while we're en route, the woman says to me, I feel like I'm having a poo, or I want to push. Okay, so if a woman says these to you, or it's getting painful, the baby's coming, these are red flags. Okay, so we're not going to give the lady gas and air to stop her wanting to have a poo or wanting to push, but what we're going to do is say, absolutely, okay, that's normal to feel like that. What I'm going to do is check that the baby is not coming. Because let's not forget that this lady's waters may have broken, but in fact, she may start contracting and she may well deliver. So we're going to think about that while we're on the way, we know that she's got a cord prolapse, but actually if she starts contracting and have pains, we're going to need to check. We're going to have to expose again, and we may well have to think, actually, we may need to stop the vehicle. We're going to communicate with one of our clinicians who may be driving, and we're going to have to say, actually, we're going to have to pull over because we think the baby's coming. And that's really important because, actually, if the baby is coming, we're going to have to think about that this cord has been out, there's been compression on it, so I'm more likely to have to anticipate performing neonatal resuscitation. So I'm going to have to think about where I'm going to do this and actually ensuring that I've got a flat surface should I need it. But we're going to have to prepare to resuscitate this baby because we don't know how long that cord has been out in reality, how long that compression is. So obviously, if we stop, and what happens? We stop and we have a baby. Let's have a look. Here we have one of our paramedics from London. And this is on the left what he looks like before he goes to maternity call. Can you see he's looking nice and relaxed? There's not many stress lines on his forehead. He's smiling. But actually afterwards, you can see that he's looking very, very relieved because he's just been at a birth. Now, this wasn't a cord prolapse, but actually it was a maternity call that he'd gone to where actually he had the same level of anxiety, even though when he turned up on scene, the baby came out and everything was straightforward. So we can never underestimate the effect of our facial features, because actually what might happen is that you've anticipated thinking, gosh, this is not looking good. But actually, whilst you've stopped and you may be considering, actually, do we need another resource to where we are if we need to deliver this baby? And that's going to be of relevance if the baby delivers and you need to resuscitate because you may well need a second crew. Don't forget, you're going to have more than one patient now. You now have 2 patients. So that's a really important consideration here. Okay, so let's move on. Let's think about what the challenges are. Let's just refresh in our minds and let's think about actually really what's been going on here. So the challenges for us then in the pre-hospital setting. If you have a look at the diagram on the right-hand side, what we can see is the cord in this case has prolapsed with the waters breaking and is in front of the presenting part. And in this case, it was the baby's head. Now, sometimes women may feel something in their vagina, and actually they may not necessarily have anything coming out of the vagina, but you may not notice it either. And that's quite a difficult situation because unless you do expose and not do an internal examination, but be able to think possibly it might be, even if she says, actually, I can feel something pulsating in my vagina, then actually it would be reasonable to consider that possibly she has a cord prolapse. And adopting this position before you get her in the ambulance is still reasonable, with an adequate explanation to the mother of what you think is going on. And there's certainly nothing about saying to the mother, actually, I think it could be the baby's cord, your waters have broken, it is possible. Actually, let's get you in the position, it'll relieve the pressure. I know it's not going to feel comfortable, but I'll do my best to keep communicating with you about what to expect. And we're going to get you into hospital as soon as possible. And as you can see with Emma on the left-hand side, that it's an incredibly unstable position if a mother is on the trolley bed, because you just can't secure her in properly, and certainly when a woman is heavily pregnant, you've got quite an altered sense of gravity. So what we don't want her to do is be injured during the process. And so it's perfectly reasonable to use your knee chest position prior to getting her onto the ambulance. And once she's on the ambulance, then get her into the exaggerated left or right lateral position during conveyance. And then if need be, during the course of the conveyance, you can then talk to her about has she got any pressure down below, and also do a visual inspection, because actually you may notice that if she does start to have her bowels open, or she does say, actually, I want to push, and you notice that the vagina is gaping and she's got anal pouting, and actually there's evidence that there's something being born here, then actually it's very, very reasonable to stop the ambulance and deliver this baby, and that is the priority. Okay, so let's just go back to that safe conveyance, importantly. So safe conveyance is about mother being in a position where she's safe to transport. You've got the lower part of the pelvis or the mother's hip, the posterior part of that hip, being elevated above that shoulder. And with the best will in the world, if you've got a very large abdomen or even a large woman, this can be very, very difficult with the best will in the world. So ultimately, the quicker you convey under emergency conditions, the better, really, because what you want to do is get her somewhere where she can have a vaginal examination performed, and if need be, the bladder can be filled, and either the obstetric team would immediately take her to the operating theatre and make a decision about either delivering the baby by forceps if the baby is very much near delivering and can be delivered by forceps, or she may have a caesarean section. Now, I haven't noted before or shared it with you, but at this point, once the woman arrives, it's certainly what you would see happen is that we would be auscultating the fetal heart. If you have a midwife on scene who is at a home birth or in a standalone birth centre, she may be able to auscultate the fetal heart and inform you about what's going on. But at this point, it's very, very difficult to know, because until you get into a maternity unit where you've got ready access to emergency delivery, it's very helpful knowing that we can listen to the baby's heart and we can differentiate that from the mother's pulse, and that's very, very important. But also knowing how well the baby's been up until this point when she's called for an ambulance, or the midwife has. So knowing about when she last felt the baby move and if that was normal for her is really key. So let's just summarise back then. Cord prolapse is an obstetric emergency, and after 24 weeks needs to be managed as soon as possible. Secondly, there are two positions that we need to focus on in the pre-hospital setting. That is the knee chest position if we are waiting for a backup resource in the form of an ambulance, and that can be done if someone else, then you're getting your other resource. But also, if you are the solo responder, then that's really key. If you're on board an ambulance and you've parked some way from the area where the woman is, then actually getting it ready and warming it up and then walking her swiftly to the vehicle is absolutely appropriate. And one of the questions I've been asked over the time I've been with the LAS is actually, what about if you're on the 4th floor and the lift doesn't work? And the same advice we suggest, you know, it's much quicker to get that woman down the stairs, supporting her and into that ambulance than it will ever be getting her into a carry chair. So we don't want her on the carry chair no matter what. Get her down into the ambulance and then get her into that exaggerated lateral position. Finally, during conveyance, if she tells you that she wants to push, she thinks she's having her bowels open, or actually, I want to push, something's coming out of me, then it's always very, very reasonable to think, actually, the woman is telling me that she's having a baby, and so it's reasonable to, first of all, expose and have a look, and actually, if there's evidence that there's a baby's head coming out, or, you know, a bottom, we're going to have to stop the vehicle and we're going to have to expedite delivery. We're going to have to make sure our maternity pack is open, and we're going to have to make sure we've got a dedicated neonatal resuscitation area and call for backup in advance. So one last point I want to think about is actually what happens in units where the access to a labour ward is not immediately accessible without going up lifts, and particularly if you don't have dedicated lifts in the units you go to. Now, it's absolutely reasonable, depending on how you pre-alert in the area where you work, to ask for the obstetric team to meet you at the entrance to where you come in. Now, this is really important in terms of a culture shift, because certainly if you're bringing a woman in and she's in this position and then you have to go into a public lift, and all the meantime you're trying to make sure that you've got that conversation going on with her and that she feels safe. And very much so, if you haven't been to that maternity unit before where there's a possibility you could get off at the wrong floor, getting them to meet you, getting that team to meet you can make so much difference to getting a really, really timely intervention done if it's necessary at this point. So at that point, we're now at 13 minutes past 8. I'm going to bring my talk to a close, and what I'd like to do is open up for questions from Andrew and our listeners to sort of share their thoughts, share their learning, share their experiences, and any questions.
I think what I'd like to do, Amanda, is put you in a pocketbook and put you in my my little snatch bag.
You mean a pocket midwife? That's what you want.
I could turn you into a little pocket Amanda Mansfield pocket app.
What, like a Tamagotchi?
never mind chasing Pokemons around. I'll just have you on the app.
Yeah. So,
ladies and gentlemen, if you have got any questions, as I said at the beginning, you can type them into the question box, or indeed, if you are feeling adventurous, you can pop your hand up now, and I will unlock your microphone, and you can ask Amanda a question live. I think we have got a question from Jack. How long does a cord have to be compressed to cause significant CO2 retention?
Okay, Jack, that's a really good question. And there is no real clarity over that period of time. And that's because often by the time that it's prolapsed, we don't know whether it's been compressed already in front of the head when the waters break. And also, certainly whether the baby has already got a background history of compromise. So to put that into context, if you've got a baby that perhaps is premature, the effect of then that cord compression, that baby's brain is probably going to be less robust in terms of its sensitivity to a deprivation of oxygen. If the mother has any background history of smoking, any kind of fetal alcohol syndrome, any growth restriction, any factors that already make the baby have exposure to chronic hypoxia, if you like. So the exact time of that compression, we don't know. And I often think about this in relation to when I talk through and when I drill on the shoulder dystocia, because we know during a shoulder dystocia, when the head is delivered, we think that in those babies that generally the rule is after 5 minutes, because the cord would be compressed during that time, that the evidence is after that time. It suggests that the baby's more likely to develop long-term hypoxic insults to the brain. And because we don't really know then with the cord prolapse, even when we talk about feeling the cord and thinking, is it pulsating? We don't really know. And so that is why a lot of our interventions about relieving it as best that we can until we get into the obstetric theatre. We can auscultate the heart and make an assessment of whether we need to deliver with forceps, if that's feasible, or whether we do an emergency cesarean. So I hope that's helped, Jack. It's probably not, because we don't know, but it just means we have to extricate very rapidly.
Yeah, it's a good question. Good question. Thank you, Jack. Next question is from Matthew. Are there any special considerations or precautions that need to be taken during delivery with cord prolapse?
No, not really, because if the baby's coming out, it will be coming out with some of the cord that's presented. And the most important thing in this situation to do is to prepare for resuscitation. So the key things that we talk about with resuscitation is we're going to think about warm the environment, close the doors and close the windows, okay? We then want to dry and rub that baby. So we want that baby to be dry so it's not chilling, because we know that hypothermic babies are at increased vulnerability, they become hypoxic, and they drop their temperatures very, very quickly in the back of ambulances. So if we're already hypoxic because we've had cord compression, it's probably going to take a bit more effort to resuscitate this baby. So the important consideration is prepare for resus, close the doors and windows, and if need be, have the baby on a hard surface, which I would say is always above the level of the waist height, so above the level of the bed, because as you know, at the bottom of an ambulance, actually, it's quite cold. So getting that area where it's warm enough is the priority. That would be, if it's a breech, then really you're going to keep your hands off that cord at all. What we don't know is the effect of touching and squeezing the cord. We assume that it vasoconstricts and it shuts it down, but we do know that babies have been born with them hanging out and they've come out and they've been screaming. So, we have to treat it as if it's the worst case scenario.
Wonderful. Thank you very much, Matthew. Doesn't seem like anybody wants to speak to you tonight, Amanda.
No, that's fine. I don't mind any questions, even if it's about other issues. I mean, one of the other things I hadn't put on here was about getting people to think about what the average length of the umbilical cord is. And I can see that we've got 41 people out there, and I'd just like to get some idea of without Googling it, how long they think a normal umbilical cord is. So perhaps I can open that up to people.
Interesting. I always get asked the question, how long should I cut it, or how much space should I leave? That's a typical question I always get asked. I normally point them in your direction.
Yeah.
Okay, we've got a question from Dave. Can I assume that the cord needs to be cut if CPR needs to be undertaken, given we need to get an appropriate area to do so?
Okay, so what I would suggest, if the baby comes out and while you're making an area for resuscitation, what you could do is deliver the baby between the mother's legs, because you have a hard surface there. And while you've delivered the baby and while you're drying the baby and you're stimulating the baby, even if you've given the baby an extra minute or two of blood flow, that's not going to impede you doing effective resuscitation, because your priority if the baby's come out and if it's in poor condition is to manage your airway primarily, because this is a baby that needs to clear the fluid from its lungs. It's the transition rather than a resuscitation, if you like. So if the baby comes out, it's very shocked and it's floppy, then the priority will be is to dry that baby, get it on a flat surface, get that airway into a nice neutral position. And if that means while your colleague is just getting everything ready, then do it between the mother's legs and actually on that hard surface. And then you can anticipate clamping and cutting the cord, because the difficulty is if you do that straight away, you've still got to move somewhere in an ambulance, whereas if you do it between the mother's legs, what you can do is that the period of time where the baby's there, it's also getting more oxygen that potentially might be coming down that umbilical cord before you clamp it. So in the new JR Calc guidance, it'll talk about delaying the cord clamping for at least up to 3 minutes. And certainly the likelihood is, and I think over the years to come, what we'll find is that we don't do any harm by delaying clamping and cutting the cord. But in fact, what it may encourage is greater maintenance of blood pressure and certainly less likelihood of a bradycardia, because you've got some blood flow going to the baby while you're attempting to ventilate the lungs. So if there is no room, and let's say the baby's just come out and it's between the woman's legs and it's hanging over the edge of a bed like a breech, then clearly you may have to clamp and cut the cord and then move the baby up onto that surface. But in the first instance, if the mother's on the trolley bed and you've just pulled up and everything's being opened and it's happened quite quickly, absolutely, get the baby up between the mother's legs, dry that baby, rub it, and by that time a minute will have passed while you're then assessing the airway, opening it up and doing that assessment of the breathing and also the heart rate. Helpful?
That was a really good question. Yeah, do you know what? The more I think about that question, Dave, the more it's a realistic question, isn't it? Should we cut the cord and move the baby away, or should we leave it there? So thanks, Amanda. It was really good, that. Next question is from Brian, and Brian wants to know, what is the technique for placing the cord back in the vagina?
Brian, that's a really good question. So this is where I wanted to throw it out to everyone about, well, how long is an umbilical cord? So if, some people in different ambulance services talk about if there's just a few centimetres hanging out, you know, and we're talking a very short bit now. I'm trying to think what I can use to describe that. So if you think about sort of 3 or 4 centimetres, that you can literally think, well, if I used one of the gauzes in my maternity pack and just very, very gently just popped it back in the vagina and popped the woman's underwear back on and got her into that, either that knee chest position if she's not in the ambulance, or into her exaggerated position, then that will keep it nice and protected. It also means, obviously, that if she then, during conveyance, says, actually, there's something coming, you can have another look. If it's a long loop of cord, then actually it's less clear, really, because you've then got to scoop it up in your hand, and then you've actually got to think about, I've almost got to reinsert quite a bit of cord. And that invariably can be quite difficult and involve a bit of handling of the cord, and we don't know the real effect of that. And, you know, personally, you know, as a midwife, if I was on scene, now assuming if I rocked up to someone's house next door without my gloves, you know, the first thing I would be doing is actually I would get her on the knee chest, and if she could feel the cord, then I may get her to pop it back in her vagina if it's a small part. But ultimately what I want to do is get her in the knee chest and relieve that pressure. So I think, to summarise that, Brian, if there's a small bit there, get a bit of gauze, pop it back in. If it's a longer one, get that pressure relieved and just protect the area around it where you can, to just safeguard her dignity.
Perfect. Yeah, I was thinking that question. That's a good question. Well answered again.
A difficult one, yeah.
Yeah. You just never know, dear, because I've delivered children before, and I've always had this thing's popped out, and I thought, I'm not sure what that is.
Yeah.
But yeah, good. Okay, we have another question for you from Sean. How best do you get a patient from a house to an ambulance when there's a cord prolapse, as well as in a transverse position?
Oh, gosh. Okay. You know, again, cord is prolapsed. Actually, you know, the most important thing is time. So I would get the woman walked to the ambulance. If that cord is out, even in the transverse, you don't know it isn't being compressed. Because even, you know, unless you're skilled at palpating the abdomen and you could look at it visually and see that it looks transverse, you don't know that there isn't any compression. So what's really important is to get her to that vehicle, assume that there is a degree of compression, walk her to it and get the vehicle to her as near as possible, because what you can do is, while you're arranging that knee chest position buys you a bit of relief, and we don't know how much relief it buys, but actually if you've got her that and then your plan is, right, let's move now, off we go, then you can reduce the time that you're arranging that kind of walking to the vehicle. So transverse, gosh, that's a really difficult one, because even in that position, you then may find actually other bits, you know, a hand may come out, or a single leg. We don't know. But ultimately, even if that does arise, what if that cord is out? Then assume all those same positions that we've talked about this evening.
Yeah, good, Sean. I you're not speaking from experience there when you're asking that question, but
No.
but yeah, good question. I have seen some quite amusing practice. I once saw an ambulance crew walking a lady down the path, and that inadvertently got a blanket between the legs, and either one of them was holding the blanket either side, almost in a catch position, like the firemen at the bottom of the burning building. Yeah, it was. I wondered what on earth was going on when I was walking up the path to us. Okay, thank you, Sean. Sorry, go on, Amanda.
Brilliant. No, go on.
Yeah, I pulled up in the rapid response car outside and looked up the path and just saw this, what looked like a circus, and I was like, all right, guys. It was like, we're just putting it there just in case this baby drops out. I was like, okay.
Fantastic.
I said, has she got any knickers on? They went, yeah. I went, well, would the knickers not catch the baby, perhaps? They went, oh, I didn't think about that. It might come around the side. Anyway, okay. We have another question from Shane, and Shane says, is the baby as sensitive to manipulation of the cord as the baby is to direct touch? Essentially, do we have to be extremely delicate with the cord, or is covering an option?
Yeah, covering is an option, and generally what you'll see is that we, in our sort of local guidance in London, and you'll certainly see it in the JR Calc, that, you know, you can, you know, you try and avoid touching it at all, but you have to think practically here. You know, I always use the example with people, and when we run our drills, we did a drill yesterday out in Hillingdon, and we had a lady who had a cord prolapse, and she was in Primark. or Primani as we call it in London. And you know what, you're in Primani and the cord's hanging out and there's quite a bit of it, and you have to think, actually, you know, we need to kind of get it to a position where it's protected, because, you know, umbilical cords are generally about 1/2 metre in length, but they can be longer, they can be 1 metre. So, you know, maybe some homework tonight with everyone is go and measure out 1 metre of cord, see how it feels if you drop down, you know, sort of 70 centimetres of that between your legs, and then try and walk around the house, you know. And, you know, I could have images of this now, but I think what's really important is you have to be practical. And I think as pre-hospital clinicians, we are very practically minded. We have to be. We go to lots of different jobs. So I think with the cord, that what you have to do is think, you know, like they did with the sling, you know, and that's a good catching technique. But you've got to think, okay, look, let's get it where it's not going to get caught. Let's get a pad underneath it. If we can put the lady's pants on, that's fine. We're probably not going to do any harm to it. But let's get her into the ambulance as soon as possible, protect her dignity, and let's get her into those positions that safeguard that cord where we know that it can make a difference. So does that help?
Hopefully that's a good answer. Thank you very much for that question, Shane. We have a question from Ian. Ian says, you mentioned options for packaging a prolapse cord. What would you recommend? Damp, non-adherent dressing or dry, non-adherent dressing, for example, cling film or other?
Right, so I'd probably say no. I'd probably say, you know what, it's just a simple dry bit of gauze. It doesn't have to be anything that's necessarily adherent. Although, you know, if I'm a bit bizarre as a midwife because I really enjoy checking placentas and umbilical cords, and I like teaching them and teaching about them. And an umbilical cord is made up of something called Wharton's jelly, and it's a really sort of lumpy gelatinous substance that contains antibacterial agents, and it coats the 2 umbilical arteries in the umbilical vein. And sometimes they can be very, very thick and look like telephone cords, and other times they can be very, very thin and friable. So it very, very much varies. So in terms of packing it, I'd almost think even if the mother's got a sanitary towel, because at some point the moisture on the cord is going to be limited anyway, no matter what. So we can't manage that. But all we can do is just protect it. So really that dressing is about protecting it rather than managing its temperature or managing the moisture in it. That seems to be what we're not so much the evidence, but the thinking is at the moment.
Good question. Thank you very much indeed, Amanda. Okay, we have a question from Craig. How much time are we giving the baby to breathe before we start assisting?
Okay, so what we're going to do is we're going to start our assessment, aren't we, in the first minute. So we're going to think about baby's born, and we're going to do the assessment of the colour, the heart rate, the tone, the breathing, and its response to stimulation. And once we're going to do that assessment, if that baby's not breathing, then we're going to start going down our neonatal life support algorithm. We're going to start thinking, let's start giving this baby some inflation breaths. Some people call them rescue breaths, but we're going to start by giving that baby inflation breaths, and we're going to start by giving 5 over 2 to 3 seconds. And what you're expecting to see in that first set of inflation breaths is we're looking for that fluid that's in the lungs, particularly if the baby hasn't cried, to be pushed out of the lungs. So normally, by that 3rd or 4th inflation breath, you'd expect that fluid to be pushed out. But if by the 5th that hasn't happened and you've reassessed, until you've achieved that clearance of the fluid, you can't get oxygen into the blood. So what you need to do is go back, check that nice neutral position, because babies have rather large occipits. So we don't want them sniffing the morning air, we want them in a neutral position. And we're going to go back and we're going to do a second set of inflation breaths. So remember, they're over 2 to 3 seconds. The objective of these is not necessarily to ventilate, it's to clear the lung fluid. Okay, so you're going to get the baby, you're going to assess, then you're going to start your intervention, and then you're going to reassess every 30 seconds. Does that make sense?
Yeah, does to me. Does to me, but it is a good question. Indeed, Craig, well done, thank you. Last question we have is from Liam, and Liam says, hi guys, I'm a trainee technician, yet to attend a pre-birth job. Is there anything we can really do regarding shoulder dystocia? Oh.
Oh, shoulder dystocia. Oh,
Ooh.
yeah, absolutely. So there's a lot that you can do about shoulder dystocia, and I would say whatever ambulance service you're in, try and access some hands-on skills drills, and you may need to approach your local maternity unit. So absolutely with shoulder dystocia, because you can do a McRoberts position, you should be able to do suprapubic pressure, but McRoberts position for the most part will achieve the birth in about 40 to 90% of cases. What I will do after this on the Facebook page is I'll show you the front of our maternity card, and it's how we are teaching people to manage shoulder dystocia. It's actually in line with the JR Calc at the moment, which we are reviewing. So it would be reasonable to look at that, but certainly look at the sphere of practice in your area, in your ambulance service. But the likelihood is that doing a Roberts position is one of the most effective manoeuvres that you can do to resolve a shoulder dystocia.
Perhaps we could do that for the next webinar, shoulder dystocia, Amanda. What do you think?
Yeah, absolutely. I probably teach it at least once a week, and it's an area that I really want our service to get really confident in, because you get a really easy win when people are drilling on it, and the more we drill, the more confident our staff become. So there's one last thing I did want to say, Andrew, just sort of while we're still here, if I got another minute.
Yeah, of course you have, yeah.
Yeah, so I just wanted to sort of let everyone know that when the waters have broken, that the inner lining of the uterus, or the membranes, the bag of fluid that the baby sits within, called the amnion and the chorion. So the innermost one is called the amnion, and the amnion continues to secrete the fluid, the amniotic fluid, even when the waters are broken. And I was thinking about back to the question that a previous listener had asked. And you may find that even when the cord has come out and you're trying to guard it, the lady may still be leaking amniotic fluid. And that's quite normal. Some women have like quite a significant amount, and it feels like the waters have kind of, you can be awashed with it. So don't be surprised if the cord's come out and she's still draining fluid, So, it may be that we can't avoid keeping it dry, but at least it may mean that if you find that that you've used a pad and it is getting wet, then change it regularly.
Perfect. Thank you very much indeed, Amanda. I'm just trying to find your Facebook page, Amanda. Have you got it on your screen that you could pop up and let us have a look at it?
Yeah. Let me just pull it up for everyone. So let me just see where my... just trying to find... Oh, right. Don't know what I've done. Let me just escape there. All right, here. Let's have a look here. So what I'll do is I'll pop it up. So can you see that there?
Yes.
So here we go. So this is pre-hospital maternity training, and please do like it. And what I will show you is we have just been doing shoulder dystocia with our clinical tutors, as you can see, and I do put lots of links up to what we're doing. So in terms of regular training, lots of pictures from we do joint training in London, and I will post some information about shoulder dystocia up there so people can look at some resources that we have available. I'm just sort of looking down. You will see this is us in the ambulance practicing some manual displacement. So by all means go on there and see what we're doing, and please do anyone that isn't in the London Ambulance Service, rather selfishly. There is lots on there. You'll also, as you can see here, there's a really good video of the current neonatal life support management by Jonathan Wiley, who is currently reviewing the neonatal section of the JR Calc. So yeah, lots on there for you to have a look at. Not that I'm promoting my own page, which I am, but generally I don't get any money for this. But it's just a portal that we use to really share good stories and learning, and enable all our pre-hospital clinicians that manage these emergencies to have a really good resource.
Wonderful. Amanda, thank you very much indeed. That's been really helpful again tonight. I'm sure all the paramedics and technicians among us, as well as all of the healthcare professionals, would like to thank you again for bringing to us a fantastic webinar. Ladies and gents,
I've really enjoyed it.
Yeah, it's been really good. We really enjoy it. And again, it was a rush. Was both rushing up the motorway early on, and we rang each other and said, "I don't think we're going to make it."
And we did. Hooray!
So, ladies and gents, I'm going to send Phil a message now. So Phil will be sending your certificates out shortly, so they will be coming to you by email. And for those people who are with CPDME, that will automatically drop nicely into your platform dashboard so that you can go in and edit and print off your portfolio whenever you need to. Just a quick reminder, tomorrow night we have got Dr. Mike Davis, who is talking about issues in human factors and design, which is interesting. It's always good to have Mike back. He's a knowledgeable guy. I think he's got a doctorate in continuing professional development, which is always good. And then we are just about to launch our next 10 webinars, which we've lined up. And so from tomorrow night onwards, hopefully, if you go to cpdme.com/webinar or just Google search CPDME webinar, you should be able to find what is coming up next online. All that leaves me to say is thank you very much indeed, Amanda, for this evening.
Yeah, thank you, and look forward to being back soon.
I'm sure you will be. And thank you very much, and have a good evening, everybody. Bye-bye and good night.